it's looking like something like 800, just under 800 potential people that they can see a week. Is that the sort of numbers you're expecting?
No, because the problem is we not the problem, but we've only got 32 dental chairs. And your arithmetic is good, but I'd probably base it on say 30. And then you also take out, unfortunately, that students have, university holidays, they have exams, they have all of that. So
nonetheless, thousands a year, right?
Oh yeah. Even more than that. Yeah.
Is this one of the reasons that you got into dentistry, to sort of make a difference in this way, or have you just sort of found yourself here by accident?
No. So I have been for most of my career, I've been both half-time in private practice and half-time as an educator. Not so much students, but most of the time educating dentists in Australia and New Zealand and around the world. And I've always enjoyed that, but I've always wanted to do more. I think the younger you get people, if you know what I mean, the more effect you can have on their career. So for me, this is a gift for me to have the opportunity to come here, and I've been amazed at how welcoming the community has been, and how the place itself, the students, the teaching staff, the admin staff, we're just a big family here, and I'm hoping that we'll stay that way.
Yeah. How much does an appointment cost?
That's a amazingly complicated question.
I thought it might be, because I was looking on your website and it's quite hard to find out.
It's hard to find out because there are a number of schemes and cards that various people have, concession cards and all sorts of. There's a lot of categories. So if anybody goes, well, you're on the website. So if you rang and asked, and then reception would ask you, do you have this, do you have that? Or you'd be able to say to them, well, I've got this, for instance. But even if you, Jesse, wanted to come and have treatment with us, for you to do that, we have I'm assuming you don't have any concessions or anything, and it would cost you $95 for the initial appointment, and that would include a full examination and history and X-rays and cleaning your teeth. Yeah,
I think anyone who's been to the dentist and paid full price would understand that $95 was a pretty good deal.
Yeah, and that's actually our top. I'd put you in our most expensive category. So many of our patients, probably the most common is that patients pay $40, and pregnant women, they're free.
Wow. You talk about the education part of it. What are you doing in that respect? Not educating your students, but educating the community. Yeah.
No, I understood. So there's two things there. One is that part of we have a simulation lab so simulation lab means we've got, I'll just call them plastic people. We've got dummies to work on, and that's largely here, although the students use it to practice a bit, it's largely here as a way to educate dentists. So we're offering and we're building up continuing education here, so that all of the dentists in the area, and from wherever, can come and do courses and either increase their level of expertise or get caught up to what the latest things are, or just get better at what they're doing. So that's one thing that we can improve if we can improve the standard of the dentist, they're going to improve the standard overall. And then the second thing is that we want to begin to get out into the community, or get the community to come to us, one or the other, not for treatment, but for education. So for things like, because most people are unaware of the, even basic oral health things. Like I know that everybody goes on about sugar, but probably the most immediate effect of sugar is in your mouth. And there's all sorts of dietary things that can improve. There's simple, just being regular with oral hygiene makes a big difference. Having regular checkups is much less expensive and much easier to do than waiting until you've got a problem. And we want to get that information out so that if parents knew more, then even if, it's more difficult for them, but at least their children can grow up knowing what they're doing, and it's improves the problem in the long term.
How do you get the information out?
I missed that, sorry.
How do you get the information out?
A lot of ways. One thing we're doing is we're going to, I'm hoping, hasn't happened yet because we're trying to find funding, but we want to have like a dental bus, and we want to have, for instance, high school kids that are interested in dentistry. We might have some demonstration sort of clinics for them to come and have a look. We're going to, over time, as I said, our website just went live yesterday, but we'll put information on that. And having the opportunity to talk to you is just fantastic, because just making people aware is and I really appreciate this, because it allows us to get the message out there. One of the things that I've noticed around here when I go into the supermarkets, I don't know whether you've ever done this, Jesse, but supermarkets in this area have a lot of products that aren't the same as supermarkets in other areas, and it's quite shocking, some of the stuff that you can't get around here. And even those sorts of things, if they change, that has a huge effect.
How much?
It's the first lectern. Check. 1, 2. Testing. 1.
Cola drinks are even worse than other fizzy drinks. I even, some people I say, well, look, let's make one step in the right direction. Instead of all the cola drink, how about you replace it with a non-cola drink, even if we've still got a fizzy drink? And believe it or not, that's an improvement. But it's horrible to be at that level where we're actually saying to someone that this fizzy drink is better than that one. It's a beginning. It's better. It's way better than nothing. And the effect it has is not just about oral health, because all of the modern research is showing us that cardiac problems, stroke, diabetes, low birth weight babies, they're all related to dental disease. And we don't know exactly what the relationship is, but there's no question if you've got better oral health, you've got better general health.
And we've sort of skirted around it already, but you really feel like you're going to make a difference in this community? Are you excited by the sorts of impact you can have?
Yeah, this is I'm really excited. I just can't tell you. I didn't really know what to expect a year ago, and actually pretty much every day since, my expectations go up, and they're still going up, and I keep saying that we're getting there, and it's not going to happen overnight, but I think we're going to make a huge impact on not just on South Auckland, but especially on South Auckland.
Finally, I just have to address the concern some people might have, which is that if you're getting dental treatment by dental students, perhaps it wouldn't be of quite the same quality, or there might be some risks involved. Would you like to address that?
Sure. I guess there's three things. First of all, the students are supervised, and they're closely supervised.
Right, kia ora koutou katoa, everybody. As a result of routine testing, I was informed late this morning that we have received an update on testing of the mother of Case C. So Case C was the young child that was previously publicly announced. The person, who is now being referred to as Case D, returned a positive test result. I want to make it clear, though, this is not a separate case from the recent Auckland cases. It is another case that is associated with the existing group. Health officials are continuing to investigate the details around that result, and the Director-General can provide some more information on that. What we do know is that the person was tested on the 27th and the 30th of January. On the 30th, they started to feel slightly symptomatic, so they were tested again on the 1st and 2nd of February, and it was the February the 2nd test that has come back with a positive result. So I want to emphasise that this is an example of the testing system operating exactly as it should. As they were a close contact of a previously identified case, the person has been in isolation, and as I've indicated, is being regularly tested. Therefore, the public health risk as a result of this additional positive case is very low. Testing rates continue to be very strong across the country. There were a total of 5,130 tests that were processed yesterday. Another strong figure which helps to provide us reassurance that if there was any community transmission in New Zealand, we would be picking that up. But we also, every time there's a new case, it is a positive reminder to us all that COVID-19 is still with us. We still need to remain vigilant. So staying home if you are unwell, getting advice about a COVID-19 test if you start to show any symptoms. Tests are freely and widely available. Encouraging friends and whānau to also stay home if they are unwell, and if you are an employer, ensuring that your employees can stay home if they are unwell. Wash and dry your hands well and often. Scan QR codes and turn on the Bluetooth tracing in the app. I'll get the Director-General to give you a quick update with further information, and then we can take questions.
Thank you, Minister. Kia ora koutou katoa. So, in total, there are 7 new cases of COVID-19 to report since our media statement yesterday. 6 of these cases are in managed isolation, identified when people arrived, and 3 of those cases actually were detected at day 01 testing. So, again, another indication of our system working well. The Minister has outlined the news we received later in the morning about what we're referring to now as Case D, who is the mother of Case C, that's a young child, toddler. Just to emphasise, as the Minister has said, this person has been self-isolating, as all close contacts do, for the full 14-day period after their last exposure to a case, and in addition to the regular testing, because she became symptomatic, testing was done on 2 consecutive days because she continued to be symptomatic, and it was the test which was undertaken by a mobile testing unit going out to her house. That was the test on the 2nd of February that we were notified this morning had come back positive. So arrangements are being made now to move her to the Auckland quarantine facility, and she will continue the period of her illness there until she is adjudged to be over that illness. Again, as the Minister said, this is just a good example of our response, our isolation and testing and follow-up system working, and I want to thank the staff at Auckland Regional Public Health who, whilst our focus may have come off here, though, because there have been no cases over the last few days, they continue the work to follow up all those close contacts and all the other testing of close contacts of both these 2 cases and, of course, the original Case A in Northland. All that testing has come back negative. All the regular case information about the 6 new cases in managed isolation and this case will be available on the Ministry of Health's website shortly. So just a few messages reiterating some of the key points made yesterday. The decision by MedSafe to provisionally approve the Pfizer-BioNTech vaccine for use in New Zealand did follow a robust assessment of safety, effectiveness and quality of the manufacturing of the vaccine. Of course, there is much more work to do, and the Ministry and the health system is working at pace on the timeline and logistics for the massive exercise to vaccinate not just our first group, our border workforce, but of course to ensure that all New Zealanders are able to receive a vaccination by the end of this calendar year. We're also developing a campaign to ensure all New Zealanders get the information and assurance they and their whānau need in preparation for getting a vaccine. We have seen from other programs over many years, our routine childhood immunisation program, and also one-off vaccination programs we have done in the past, like our meningococcal campaign in the early 2000s, that the ability for people to access sound and reliable information from people they trust is critical to ensuring strong uptake of vaccine. And making sure this information is readily available is a key priority for me and our team at the Ministry of Health over coming weeks and months. And finally, it is pleasing to see the ongoing good volumes of testing happening in the community, particularly in Auckland and around Northland, which continues to provide us with a level of reassurance that we haven't seen any community transmission from those 3 and now 4 cases that we've found over the last couple of weeks. And I think that's particularly reassuring as we head into this weekend's long weekend Waitangi holiday break. Thank you, Minister.
Thank you. Questions?
Can I get a clarification just on the what you were saying? So, person C is the child?
Yes.
Okay. So it was the father that had originally had COVID within the managed isolation facility.
That's person B. Yep.
Yes. And are there any other close contacts being tested now as a result?
So there are some close contacts of case D, who were also close contacts of cases B and C, and they will continue their isolation period and be tested. And yes, just to go back to the earlier question, it's not clear whether case B or C was the first of those cases, but clearly as part of the same family unit, that the spread happened within that family unit.
Are we certain that the woman has been self-isolating, that she hasn't visited any other stores, shops, events, or anything of the like?
Yes, with a high degree of confidence in that. She's been very cooperative, and the public health unit has been in regular contact with her, as you can see with the testing and the reporting of symptoms, and she's been very clear about the need to isolate her during that period.
Why did the test take so long? It's normally just the next day.
Yes, so when the test may have been done later in the afternoon on the 2nd, processed yesterday and at some time during the day, and the result would have gone into the system overnight and then was picked up in our system this morning, remembering that she remains isolated while that test result is coming back.
In terms of the sequence, just correct me if I'm wrong, but I think you said that there were tests on 2 consecutive days. Why did it not detect on the first day even though she had symptoms?
Well, I think this is a good example of the variable nature. You have some people, of course, test positive who are completely asymptomatic and not even aware they're infected. Others have quite significant symptoms, but it can take 2 or 3 days before they are shedding enough virus, particularly in their throat, that the test picks it up. And I think in this case, good work by the public health unit. Because she remains symptomatic, they repeated the test on consecutive days.
How are people who are required to be in isolation being tested? Do they have to go to a testing centre, or is there a mobile testing centre sent to them?
It depends really. If there's a testing centre nearby that they can get to, and that they have strict instructions about how to do that. So very often if they're tested even by a GP or at a GP clinic, that will be done while they remain in their car, so the GP or nurse will come out and do that in the car park. Of course at our CBACs, again, it's all done in the car, and they're not exposed, no one else is exposed, and the person doing the test is wearing full PPE when that's done.
So the 3 new ones in managed isolation that weren't detected after day 0, were any of them on a day 12 test?
Just looking at the information here, so 3 of the 6 today were on a day 1 routine test, 2 were on a day 3 routine test, and the other was day 8 because they became symptomatic, so was tested sort of out of cycle. So remembering that in addition to the regular testing, every day, every person is asked about symptoms and run through that, and if they have any symptoms, then a test is done at that point in time.
Or is the day 8 one? Do you think they might have caught it in MIQ?
Actually, it says they were in Jet Park. Now that may have been because they were, it's not here, they may have been a close contact of an existing case. But in fact, all of the cases being reported today, it says they're in Jet Park. Some, like the day 01 people, may have been symptomatic on arrival, in which case they go directly to the Jet Park, the Auckland quarantine facility.
This is where us, and we're one of the only countries that is doing this, doing the genome sequencing for every case that we get. means that if there are matches with cases in managed isolation or in quarantine, we can identify whether there was good reason for a match. So, for example, if they came in on the same flight, tested positive about the same time, then you might expect there to be a match. That wouldn't necessarily raise a concern. If, on the other hand, they're testing positive with a genomic match for someone who is completely unrelated, then that would be something that we would bore into in great detail to find out what's happened there.
The investigation into the Pullman Hotel was due to report back yesterday. Have you seen that report yet already?
No, I haven't seen the final results of that. As I indicated, I think earlier in the week, the timetable that I set out, the Pullman Hotel will be empty by Saturday. So the last of the guests are due to leave on Saturday. And then there'll be a period, probably of at least a week, where we do some upgrade work there. We make sure the CCTV is fully updated. There's a thorough clean of the hotel. During that time, any changes to the operating procedures around the Pullman Hotel can be made, and then a decision would be made whether or not to fill it up again, and if so, whether any changes should be made on the number of people that we have in there, and so on. So that actually, the timetable for that aligns quite well with the fact that by tomorrow I'm due to receive advice on the cohorting, changes to the way we cohort people within our managed isolation facilities. So all of that will be considered together.
Why are the results being delayed?
Look, I haven't received those results as yet. They may have arrived in my office. I haven't seen them as yet. But when they do, I'll be looking at them. But like I said, the key thing here is that the Pullman will not be occupied after Saturday until such time as we're confident that we've understood what's happened here. The risk has been minimised as much as possible. I never want to say eliminated, because there's no such thing as eliminating all risk, but the risk has been minimised to the point where we're confident to be able to use that facility again.
Minister, on the COVAX delivery, New Zealand's due to receive 249,000 doses of AstraZeneca, including quite a few in Q1. First question, is AstraZeneca going to be likely to have MedSafe, yes or no, before it actually arrives in this country? And second question, why are we actually getting any vaccine via this scheme at this point, given it's mostly for moderate to low income countries and we already have side deals for millions of other vaccines?
So part of what COVAX is designed to do is ensure the efficient use of vaccines, to make sure we're not wasting vaccines. So New Zealand has a deliberate strategy of over-ordering vaccines. We can re-release vaccines that we're not going to use back through COVAX to ensure those other countries can have access to them. So it is important that New Zealand's part of a facility like COVAX. There are timing and sequencing issues that are being worked through there. I got some information about that, I think probably on the same timetable that you did, in the last sort of 24 hours, about when we might see that first arrival of AstraZeneca vaccines in New Zealand. And we're just working through our timetables to make sure that we can respond quickly to that. My understanding is that the AstraZeneca MedSafe application is now in. It's only recently been submitted. MedSafe have been preparing for it, so they've been gathering the evidence and the data before the application was even received, so that they can process that as quickly as possible. Now, they'll still do that very thoroughly, though. One of the things that we've been very clear on here in New Zealand is that we are not using an emergency approval. We're still running our regular approvals process, and they will run a thorough approval process for the AstraZeneca vaccine as well.
Possible, but you'll essentially say, no, we don't want it. We're getting enough of our own vaccine for us ideal, and you should give us to other countries.
Not necessarily. I think it's still too premature to comment on that. We're still only dealing with indicative timetables rather than rock solid timetables, both for AstraZeneca and for Pfizer. We know that we've got a commitment in the first quarter, but at this point the actual delivery schedule is still tentative. So at the moment we're still keeping all of our options open.
Then give it to the Pacific.
Jessica.
Is that if we did get that, could we then pass it on to the Pacific? Is that how it works?
We are certainly working on the basis that New Zealand will have a very, very active role in ensuring the supply of vaccines for the Pacific, and that we will partner with them as well to make sure they're in a position to be able to deliver them.
On the AstraZeneca vaccine, there has been developments that it's now less likely to transfer. Is that good news? I guess a two-part question. Is that good news for us because we've ordered such a big lot? And also, will people get to choose which vaccine they get if they see one as more favourable?
I'll comment on the last part, and I'll get the Director General to comment on the first. New Zealand's overall decision to use framework is based on science. It's based on us looking at each vaccine, working out who is this which population group is this vaccine the most effective with, and that's how we decide who gets what vaccine. So it's not that you just get to rock on up and take your pick of the four. We will actually make some decisions about which population groups we're going to use the supplies of vaccines we get for. And of course, as the science continues to tell us more, then we have the ability to, to fine-tune and refine that program as we go along. But on the first point, I'll ask the Director-General to comment.
Thanks, Minister. Yes, I think this emergent evidence around the impact of the AstraZeneca vaccine on reducing transmission is really encouraging. And we will see this emerging quite quickly for all the vaccines that are in use, including the Pfizer one, which is obviously the first one we're getting. So this is one of, again, the advantage of a number of millions of doses being given in a number of countries, and the very rigorous ongoing monitoring and reporting. So this is information that we will be able to use to inform also our decision to use framework, which is, and the leadership of that around advice is with Professor Ian Town, our Chief Science Advisor, and that Science and Technical Advisory Group. You could imagine a situation where we had 2 or even 3 vaccines on shore at the same time, and we would want to be thinking, okay, how do we use these different vaccines best for different populations to ensure we get the highest possible both coverage but also response and immunity.
Back to the community cases, are you expecting any of the close contacts of case A through D to return positive tests, considering it did take case D a few days to develop symptoms and eventually test positive?
So that's one of the reasons that we have the very rigorous close contact isolating and testing process that we have, so that if someone incubates the virus for a period of time, we've made sure that they're isolated and they won't have been passing that on to anybody else. But I'll ask the Director-General to comment on that too.
So, yes, and to your particular question, we're not expecting anybody else, recalling that this was the very close household contact of cases B and C. And in our first case with case A, the very closest contacts actually didn't transpire to become infected. But we're not expecting any other positive results. However, every single close contacts will see through that 14-day period and, of course, have that day 12 testing. Most have had that already and they've all returned negative so far.
Henry.
Minister, on Pfizer, have you got a contractual? Do we have a contractual requirement to deliver vaccine to New Zealand in Q1, or is the contractual requirement on Q1?
Yeah, so we've agreed an indicative delivery schedule with them that would have, I think, 226,000 doses arriving in the first quarter.
Do you regret your front of the queue phrasing?
No, I mean, I think the world has changed a little bit since then, in the sense that, many countries have been running emergency vaccine campaigns. So I think, when I made those comments, I was looking at it in terms of a normal vaccination program. When vaccines started to be delivered for a regular vaccination program, we are going to be among the first countries to be doing that. We've made the decision, and we made the decision late last year, that we would not engage in an emergency approvals process in an emergency vaccination campaign. We don't have the public health grounds to do that in New Zealand, and I fully understand why the countries that are doing it have been doing it.
You mentioned how you're going to be...
I'll go to Jessica.
The Director-General yesterday mentioned that those in the first batch, those needing very serious respite care or hospital care for elderly will be first in the queue. Where do other people over 65 fit? Are they next? Are they that second tier?
Yes, broadly, but again, that's going to be something that we're refining. The decision to use framework, we refine that as we go along. So we'll refine that based on when we, how many vaccines, which vaccines, when we get them, all of those things. As we get more information to plug into the system, that will help us to refine the prioritisation process.
So depending on how long it takes to get those AstraZeneca vaccines that are most suitable to those over 65 may depend on where in the schedule they get vaccinated. Is that correct?
Yeah, look, like I said, the whole program is subject to refinement as we go along, and depending on what we get delivered and when we get delivered it. Obviously, our goal though is to get to the point where we can be making vaccines broadly available to everyone as quickly as we can. But we have been clear that that's likely to be second half of the year, hopefully early in the second half of the year, rather than first half of the year.
Are you looking at
even contracting other vaccine manufacturers if they prove to be more effective? Moderna, for example, you're looking at the efficacy of everything as it comes in. Could we see other vaccines ordered if they prove to be better than what we've already signed up for?
We've signed up for a broad portfolio of vaccines. If you look at Moderna, it's a very similar vaccine to I think it's the Pfizer vaccine, which we have ordered. So we're not seeing any results from Moderna that aren't comparable with what we were seeing from Pfizer. We've taken, as many other countries have done, a broad portfolio approach, so different types of vaccine, and making sure that we've been buying into all of those. You never say never, though, and we have the ability, further down the track to add additional vaccines in. We also have to think about the fact that this is likely to be an ongoing need. So once we're through this first wave of vaccinations, we're likely to need a maintenance, vaccine maintenance program where we will be purchasing regular ongoing Covid-19 vaccines, just as we do with influenza and other things that we buy vaccines for. Okay.
Well, Dr. Bloom,
One last question.
Dr. Bloomfield, can I ask you about the whether you've had any briefings on the high levels of lead down in Otago that you've done in the water and what those briefings have told you?
Yes, I have, and I asked the team this morning for a briefing, and they've been on the phone with the public health unit down there and the city council and the organisation that does the water testing. So they just sent me some notes just before this, actually, a briefing, and what they are planning to do is to offer blood lead testing to the populations of the two places affected, and they're just working through the logistics of doing that, standing that up next week, which I think is an absolutely appropriate thing to do. The Medical Officer of Health down there, Dr. Susan Jack, is driving that, and I support them doing that, and I've asked the team to keep a close eye on that, so we've set up an incident management team to ensure we're getting regular updates on progress with that.
What sort of risks are there to people's health with drinking high levels or water with high levels of lead in it?
Well, the main impact of lead is actually, the main concern over many years has been on the impact of longer exposure, particularly for children, in terms of neurodevelopmental effects. What's not apparent from the testing is that is the length of any exposure and what variation in levels there may have been. So there's further testing being undertaken, but I think the appropriate next step is to offer blood lead level testing to the residents there, both children and adults, to be able to provide them with reassurance about any lead exposure they may have had. That will give us a better idea.
Do you have any concerns about the way that local authorities down there have been handling this? I mean, not reading an email for over a month, even though...
I don't have enough information to be able to comment on that.
So just got two more questions for two different colleagues. The first question is, how much thought's been given to vaccinating athletes and bumping them up the list ahead of Japan? Because there's growing concerns they won't be allowed in unless they're getting that vaccination.
Look, I have received some correspondence about that. The advice that I've had so far is that they would need vaccinations towards the middle of the year. We may well be in a position where vaccines are widely available enough for them to get vaccines on the timetable that they would need them.
Would they be prioritised?
Well, like I said, it's quite possible that we are going to be in a position where vaccines will be widely available at that point, so they'll be able to access them anyway. If we're not in that position by the time that they need them, then we would consider that in advance of that. At this point, we haven't made decisions on that.
Can I just ask about the death in the Crown Plaza last night as well? What information can you give us about that and what assistance was required?
My understanding, it was not COVID-19 related. It was an REC worker coming into New Zealand, and I don't have further information on the particular cause of death, but obviously it's a tragedy for that person and for their family.
Just to clarify, Minister, just on the Pfizer vaccine, so it's 225,000 courses, 450,000 doses in the first quarter.
As the first drop, yes, actually. So that's guaranteed in the first quarter, and there may be more, of course, but that's what they've said. Pfizer have said they'll be able to deliver in this first quarter.
And did you know also about the label botch-up as well? How widespread was that in Northland, and have you been able to get any more information about that since this morning?
No, I haven't, and not so much a botch-up, but just sometimes there are errors in or something happens in the whole process of labelling a sample or data entry, it may have been just one figure that was incorrect, and therefore, and the lab have very rigorous protocols about processing of samples, and if all the information isn't on a sample and they can't match that with what is in the database, then they won't process it and they will go back and be resampled. I think there were 3 instances among the many thousands of tests done over the last couple of weeks, and of course there have been about 800,000 tests done in the northern region since testing commenced there.
Lucky last, Audrey.
Yeah, okay. You said yesterday that you thought New Zealand's and Australia's Pfizer would come from the same batch. Would that make sense for them to be transported at the same time by Pfizer? And in which case, might New Zealand be piggybacking on the fact that Australia's getting them a bit early, so we might get them early?
The indications that we've had from Pfizer is that our 226,000 would not all arrive all at once, that they're likely to come in smaller instalments, potentially sort of week after week. And our focus is on gearing up and being ready for the first smaller batch as soon as it does arrive. And so it's likely that Australia will be in a similar position to us. Obviously, we're not party to the conversations between the Australian government and Pfizer, but I can say that our delivery schedule, and it's still only, the indications we're having from Pfizer, it's still only about 70% sort of locked in because they're dealing with a number of different things they're working through. But as soon as we get up to that point where we're certain of it, we'll tell you what that is.
And are they responsible for the transportation from the manufacturer to New Zealand soil, Pfizer, or rather than us?
Yes, they are. So we take ownership when it lands, and we have verified that the contents are there and that the cold chain integrity has been maintained through the flight. Then New Zealand takes ownership of the vaccine.
All right. Thanks very much, everybody.